Today I will be presenting Samuel Olson, a 2-year-old African American male who presents with fever and ear pain. The chief complaint per his mother is Sam is running a fever and pulling at his ears. Using Old Cart's framework for his history of present illness, his symptoms began 2 days ago at daycare. The pain is located in both ears. It has been constant and is described as throbbing. It is worse at night with no true relieving factors. Although Motrin has been provided for partial fever reduction, the timing is persistent over the last 48 hours, and the severity is rated 6 out of 10 per his mother. There has been no recent travel. In terms of medication, he's taking children's Motrin, 5 mils every 6 hours as needed. He has no known drug allergies. His past medical history is unremarkable. He was born full term without complications and is meeting all of his developmental milestones. He has no past surgical history. Family history is non-contributory. Socially, he lives with both parents, 2 older siblings, in a stable smoke-free home. There is no substance exposure or safety concerns reported. On review of systems, he is positive for fever, irritability, bilateral ear pulling, and sleep disturbance. Mother denies any ear drainage, hearing loss, cough, congestion, vomiting, diarrhea, urinary symptoms, or being lethargic. Moving on to objective findings, his temperature is febrile at 39 degrees Celsius with all other vital signs within normal limits for age. On exam, he appears mildly ill but is alert and consolable by his mother. So the head, ears, nose, and throat exam reveals bilateral erythematous bulging tympanic membranes with loss of bony landmarks and decreased mobility on pneumatic otoscopy. This is consistent with middle ear effusion. There is no perforation or drainage. Ear canals are clear. He has mild, mobile, non-tender cervical lymphadenopathy. The remainder of his physical exam is unremarkable. Based on his history and physical exam, my primary diagnosis is bilateral acute otitis media. Pathophysiologically, this likely began with viral infection, causing inflammation and SGN tube dysfunction, leading to fluid accumulation in the middle ear and secondary bacterial proliferation. His age increases his susceptibility due to the shorter, more horizontal SGN tubes. My differential diagnoses include otitis externa, which is unlikely due to absence of canal inflammation or tracheal tenderness upon physical exam, and streptococcal pharyngitis, considered due to the high fever and the lymphadenopathy, but unlikely given his normal throat exam. Moving on for our plan, given his age, bilateral involvement, and fever, I will initiate amoxicillin 500 milligrams orally twice a day for 10 days as our first-line treatment. For symptom management, he may continue the weight-based ibuprofen and alternate it with acetaminophen as needed to get better coverage. Non-pharmacologic recommendations include adequate hydration, rest, upright positioning to decrease that pressure, and warm compress for comfort. No additional diagnostic testing is indicated at this time, as diagnosis was confirmed clinically with pneumatic otoscopy. They might do a temp centesis if referred to a specialist, but this is an uncomplicated case. Other lab work for a complicated case would be a CBC and ESR, just to see what type of systemic response we're having. So I provided caregiver education emphasizing completion of the full antibiotic course, expected improvement within 48 to 72 hours, and return precautions included persistent fever, worsening symptoms, decreased oral intake, being lethargic, or signs of allergic reaction. Culturally, I ensured education was delivered in clear, family-centered language and allowed for time for questions to support understanding and adherence. For health promotion, we discussed hand hygiene, minimizing sick exposure at daycare when possible, of course, and maintaining up-to-date immunization. He will follow up in 1 week to ensure resolution or sooner if symptoms fail to improve to our current treatment plan. If infection becomes recurrent or persistent, referral to ear, nose, and throat would be indicated. In summary, we have uncomplicated bilateral acute otitis media, appropriate for outpatient management with oral antibiotics, supportive care, and close follow-up. Thank you.